Typhoid recap. Typhoid is an ancient disease. We know the history of typhoid Mary, interpersonal transmission, and the epidemic disease, food and waterborne disease caused by Salmonella typhi and Salmonella paratyphi. So, orophycal transmission, sanitation, interpersonal transmission, poor sanitation, and your intestinal infection. The intestinal lymphoid tissue, they walk, they start to defending the person with, with primary, there can be your primary septicemia and one stage, and when it spreads to the system, the different organs, seeds into the spleen, reticular lymphoreticular system, liver, gallbladder, and other sites, heart, even lung, brain, and other parts of the intestine, even bone. So widespread disease. So this is a disease without any focal or local neurological sign, or deficit, and without any focal sign. You won't get anything in this fever with any focus. No throat infection, no chest infection, no UTI features, no abdominal infection features. But we have widespread. That is, it is a primary and secondary septicemia, seedling of the virus and the bacteria into the different organs, have the symptoms, and the toxemia at times in severe infections is predominant, and thereby there is a different sort of disease. Usually your gut is most severely affected. You have abdominal distension, you have bloating, you have barbaric mexical gargling, and in system you have your relative bradycardia. We know that the pulse rate increases by 10 beat per minute for 1 degree rise of fever. Here you have peculiar things. It is relative bradycardia. That is 1 degree Celsius increment of temperature doesn't give rise to the more than 10 beats per minute of heart rate. And also the organ-wise symptoms, splenomegaly may be there. In skin, there may be red rose spots, and and other focal signs. In the brain also, the metastatic infective foci, you may have the delirium, deterioration of consciousness in severe worst sort of cases. And even in kidney, you can have nephrotic presentation, and other organs, liver, cholecystitis, hepatitis presentation, all are possible. So in skin, you have red rose spots. So these are the presentations of enteric fever. How do you diagnose? You diagnose it by the your first week blood culture. In second week is stool and urine culture. Third week or so, and Beadle test. It's an agglutination test, non-specific test, but it is the commonest test which is possible in good amount of cases throughout the world. The If you took the the blood culture, it is positivity is around how much, 50%. You have, if you take the sample from the red rose spot, skin puncture, 63% positivity. And if you take the your bone marrow, it is little bit high, 93% or so. But the invasive procedure most of the time is not being done. So this is how you diagnose typhoid, and your others are the non-specific inflammatory markers. And finally, the how do you treat enteric fever? Differentially, you have dengue. Currently, epidemic is going on over here, and you have the and other infections who have these sorts of fever without focal sign, and you have rash. You have little bit of hepatosplenomegaly. Most of the time, you do not have anything palpable or examinable. You have toxic child without any definite focal sign. This is how you diagnose enteric fever. Fever is a little bit more, this is a little bit on a higher grade, continued type of fever. This is characteristic. So certainly the dengue, it comes, the other fever with rash, they also come depending upon the presentation. The cholecystitis, if you have the liver involvement, gallbladder involvement, and so forth. So how do you treat? Treatment is basically the antibiotic. The first line may be ampicillin, amoxicillin. Maybe once upon a time, chloramphenicol, we used it a lot, but it has a grave side effects like bone marrow suppression. Thereby, people are now not using it nowadays. And you can use also erythromycin, but it's a poor choice. Good choice in the moderate to severe disease is ceftriaxone. So the sad part is that there is drug resistance. We call the when the three drug resistance is there, the ampicillin, azithromycin, and your chlorphenicol, all three resistance. We call it multi-drug resistant enteric fever. When the ceftriaxone is also resistance, 80 to 100 milligram per kg daily, and you call it your extended drug resistance. So this is what is happening in the globe, but this is not that common, but possible. So drug resistant cases can be dealt with the carbapenem derivative like meropenem and few more other things are there. The ciprofloxacin or then quinolones. They are once upon a time also useful, but the resistance against them is quite high. The reported around how much 80% resistance of ciprofloxacin and quinolones are being reported. So thereby the treatment is the most probably in average to moderate to severe cases is ceftriaxone 80 to 100 milligram per kg per day and other supportive care, nutrition, food intake, and taking care of the other symptoms, paracetamol and others. So, good amount of time. I said earlier, you have primary and secondary sepsis. So, endotoxemia is there. You can cut down the endotoxin release by a little bit of steroid. 2 to 3 days. Prednisolone, even dexamethasone, do 2 to 3 days, and sharp, no tapering, small dose. They reduce the toxin release, and they are very useful at times. Not a usual practice, but it is an option available over here. Ultimately, in the long term, the prognosis is good. Small amount of cases, 2%, 3% case fatality is being reported throughout the globe.